Good morning. I'm always amazed when I see all these faces, and most of them I know, which I think is kind of scary on both sides, I suspect, of this podium. I would like to start by thanking you on behalf of our steering committee for this summit for coming today. I know that you're all profoundly busy. We're all profoundly busy, and I think the next 2 days will probably explain many of the reasons why. So I really want to thank you for attending, for sharing your knowledge and expertise, and for giving so generously, really, of your valuable time at this. It's always a busy time of the year now, actually, but certainly it seems to be more right now. I would like to say that we did not invite Andre Picard to be on any of the panels, so I just want to mention that because you might think that he's stayed away because there aren't enough women at our conference, but I think we really would have met any conditions that he might have put on representation on our panels. We have lots of everybody on all of our panels. So he's not here because he turned us down. I just want to be really clear about that. For those of you who don't know that joke, I'll explain it to you later. Some of you do.
Totally lost.
So you're lost?
Later.
I'll tell you later. I think that really, you're going to learn a profound amount from the amazing lineup of panelists, but also, and almost more importantly, really, from our collective experience, skills, and passion that I know is in, all of which I know are in this room. And my hope is that we're going to leave here with some refreshing and creative ways to develop an enhanced, patient-centered, sustainable, and equitable healthcare system. It's not a small task, but I actually know that the people in this room are more than up to it. Unfortunately, it's the people who aren't in this room that may be more of a challenge. So I have to tell you, and I think those of you who know me well will know this, everybody knows how I'm feeling about anything at any particular time. I'm not exactly known for my stoicism. And so I want to say that, you know, I've really felt lately that we always live in challenging times, but I've really felt lately that we've been living in what I call Cassandra-like claims, that our present healthcare system is unsustainable, unaffordable, that drug prices for innovative drugs are outside the price range of public and private plans, that there's nothing to be done but find some lowest common denominator for all, which some people are calling universal drug coverage, but I certainly wouldn't, and be satisfied with the fallout from that. And I confess, and those of you who know me know this is true, that over the past few months I've almost succumbed to the siren call of mediocrity and despair. And when you listen to the present state of our system, as you're going to over the next couple of days, it's easy to fall into a sense of feeling like a fly caught in a series of complex, perplexing, and frustrating systems that are impenetrable in some cases and deaf to our advice in others. By the way, this is by no means a criticism of the hardworking civil servants and other public and private sector representatives who are here today and will be here tomorrow. I believe they will describe valiant attempts to work within the system they have inherited. In my opinion, it's just that this system is fundamentally not constructed for healthcare in the 21st century and beyond. And frankly, in my view also, continued tinkering just won't get us there. What brought me out of my despair and discouragement was hearing a panel of the three people I'm about to introduce a few months ago, and I hope that they will take you out of your despondency as well. The concept that they're going to describe, one of health outcomes measurements in health, rather than the present siloed health output system, gave me hope. Enough hope that I agreed to be a champion for it with others across stakeholder groups in Canada. I sincerely believe that it will transform healthcare in a badly needed way. It's a concept that has been endorsed by the 35 member countries of the Organization for Economic Cooperation and Development and by the World Economic Forum, as you'll read in the paper that we've provided for each of you. I think it's an excellent summary of this concept. I warn you, though, that as with all transformation, present vested interests, the ones who aren't in this room, will find every argument they can as to why this is not feasible. Change is never easy, especially when money is involved. I take heart, though, that the barriers they will create can be overcome. And I take comfort from words from a very visionary person whose book I recently read. His name is Thomas L. Friedman, and the book is Thank You for Being Late, An Optimus Guide for Thriving in the Age of Acceleration. If you haven't read it, I strongly recommend it to you. It'll keep you from being afraid of being near sharp objects. So he says that the pace at which accelerations in the economic market, the environment, and the exponential growth in all areas of health endeavor, including healthcare, are taking place at a speed that is like dancing in a hurricane. I really like that expression. And he says, some politicians will try to build a wall around this hurricane. I think we actually know some of those politicians. And he says that's a fool's errand. Rather, he counsels us to dive into these accelerations and to build healthy communities based on mutual trust and respect. Without trust, he says, and I agree, we will only cooperate formally and by coercion. With trust, we will think long-term and collaborate on new ideas, be willing to experiment, and not dwell on every mistake along the way, but embrace each as part of the growing experience. With that introduction, I welcome three people who are optimists and forward thinkers to introduce the concept of health outcomes measurements. You have a full not a full, but you have a fuller biography of each of them with your materials. So I'll just say a few words, personal words. First, one of my new best friends and colleague, Andre Diaz. I hope he would say the same.
I would.
He's worked for some long time at the International Collaboration for Health Outcomes Measurements, from a time when there were few proponents for this concept. But at a recent conference, international conference that I attended on this concept, there were 650 people from several countries in the room. That's a big step forward, for sure. Most recently, he's returned to consulting, but he continues to champion this work. And he'll speak first. And he's going to be followed by TERRI LOHNES, who is a consultant with a leading management consulting firm, Optimus ISBR, and she's the leader of their healthcare and not-for-profit group. She was part of this wonderful panel that I heard before. She's had 20 years experience in the healthcare sector in a variety of positions, including a stint in the Office of the Premier of Ontario, responsible for the startup and oversight of the Ministry for Research and Innovation. Perhaps on the break she'll tell us some good stories about that opportunity. And last but by no means least is Fred Horn. Many of you probably know him as the former Minister of Health for Alberta, and he's now a consultant with 360 Public Affairs. I always want to say 360 Public Affairs. My favorite comment of Fred's, which he may actually use again this morning, is that when he was running for office in Alberta, everyone begged him to make change in healthcare. And he said that once he became the Minister of Health and he proposed to implement some changes, everyone told him not to change anything. Doesn't sound very far-fetched to me. As he will tell you, he has reached his own conclusions about what makes sense for healthcare in Canada. So with no further ado, I would like to introduce Andre Diaz.
Thank you, Louise. So I have the pleasure of kicking off this panel on kind of value-based healthcare outcomes measurement and why it's important. Maybe I'll start with a short story. I want you to put yourselves in the shoes of a man who's about 55 years old and has just been diagnosed with prostate cancer. He's been told that surgery is the most likely, or is the best option for him. And so he's sitting in kind of the surgeon's waiting room and thinking a bit. Now, there's hundreds of questions probably flowing through his head. But the two big ones that would probably boil down is A, will I survive? And B, what will my life be like afterwards? Now, when he sits down with the surgeon, she'll be able to answer A quite well. The will I survive question is one we know a lot about. We measure mortality as an outcome across most developed countries in most types of care. And prostate cancer in particular is one with pretty good mortality. If you go to most hospitals post-surgery, the one-year mortality rate's in the 95 to 96% rate, and it doesn't really differ much between places. And so that's, really a good sign. But that second question, which is really along the lines of, what will my life be like after the surgery? The answer to that will be, it depends. And it does depend. It depends on a lot of things. It depends on what kind of patient you are, what kind of cancer you have, but it also depends on where you go for that surgery. If you were to go to MARTINE Clinic in Germany, which is probably one of the best prostate cancer or radical prostatectomy centers in the world, your chance after that surgery of having incontinence or erectile dysfunction would be around 1% and 30% respectively. If you went to really any other hospital in Europe, your chances would go to 4% for incontinence and around 70% for erectile dysfunction. That's a massive, massive, massive difference. If you just think of it, it's fourfold on can you pee on your own, and almost 2.5 on will you be able to have a sex life. These kind of outcomes are the ones that matter most to patients after survival. But they vary dramatically depending on what type of treatment you get, depending on where you get that treatment, and depending on how you are serviced as a patient. And the question is why? And that's one that comes up again and again in different countries and in different geographic zones. Why are there such massive differences in these outcomes? And the simple answer becomes is that we don't measure them. We measure the big things like mortality that cross disease conditions. We don't dive one level deeper at a disease condition level and measure those outcomes that would matter to patients within that disease. And that is actually the foundation of the problem. Because if you don't measure it, you don't know what improves or what is causing benefits or downfalls, and you can't actually synthesize a good argument about how to improve. And so this is really where value-based healthcare as a concept comes in, which is that value-based healthcare says that the fundamental unit of measure for everything we do in healthcare should be something called value. And value is the outcomes we achieve for a patient at a disease condition level over the cost to achieve them. So let's talk about what those two are, because when you say outcomes, it's kind of like a generic term, and I see the word outcome pretty much on every slide I see in healthcare, I think, nowadays. And so what is an outcome? Outcomes in value-based healthcare are those things which you achieve at a patient level that are disease and condition specific. So let's think about that. What does that mean? If you are someone going in for a hip or knee surgery, the outcomes you would care most about are, first is kind of survival, but the second is recovery time. You would care a lot about physical function. When do you receive and return to full physical functioning? You would care a lot about pain. How much pain will I experience, and when does that pain threshold go down? And those would be the main things that you'd actually want to measure the success of your surgery by. Currently, we don't measure them. Pick a different condition, rheumatoid arthritis. Here you would want to measure, well, how often do I have flare-ups? How often do I have to return to the hospital? How well is my pain managed? Again, these are the outcomes that make sense at the disease condition level, but aren't quite captured. And I think many of you are probably sitting there thinking, you're like, well, you know what? I talked to my doctor about some of these things. We track them one-on-one kind of in a symptoms questionnaire. And so we are already, to some extent, measuring outcomes. Totally true. Many physicians, many clinicians will actually do this with their patients. Many patients will do that on their own. And so outcomes aren't a new thing. The issue is that if everyone measures a different thing, and everyone kind of does it in an ad hoc way, you end up with an inability to compare those outcomes between people, between hospitals, and between countries. And that lies the problem. So you actually have to have a standardized set of things that you measure at a disease condition level, and that's what you would call a set of outcomes. So that's the first part of value-based healthcare. We need to have a standard set of outcomes by disease condition so that you can actually know what to measure and then have a comparative unit of quality between different types of treatments, different people, different hospitals, really something to measure ourselves by. The other side is, what does it cost to achieve these things? And the cost to achieve these things is important because you want to say, well, if I can have half or a 50% improvement from a pain perspective at 3 months post-surgery, how much does that cost me? And what are the trade-offs? Can I put that money somewhere else that makes more sense or less sense? And you can look at that more objectively. And I think this is where value-based health becomes really interesting, which is that once you have a standard unit of measurement that you can all kind of align yourselves around, you have something which we haven't had in healthcare pretty much ever, which is what I would call as aligned incentives. Right now you have different parties in healthcare, and let's split it into just the 4 main parties, which is clinicians, patients, med tech and drug companies, and governments. Now each of these groups currently has to kind of fight for what they believe is most important, but their incentives really aren't quite aligned. If you are a clinician, from a payment perspective, you're really incentivized primarily based on the volume of work you do, and not necessarily on what you deliver to patients, but how much you do in a given day, a given month, a given year. Now, physicians valiantly fight against this, and in many cases go over and above to try and do more, but they're really contravening their own monetary interests in many cases to do that. And so they're trying hard, but they're fighting against the direct incentives that are set for them. Patients, you don't actually get to know what are the relative differences in outcomes between the places you seek treatment, between the drugs you are given, between the types of treatment you can focus on. And so you have no choice but to kind of fight through each individual one and try and say, well, I would like to get more of most things because no one's giving me any information to tell me what will result in the best possible, not only survival, but overall long-term health care for me as a patient. And so that's the only goal that you can actually achieve, which is what can I get more access to in the hopes that more will equal better, which isn't often true, but it's what we're left with. On the side of drug companies, if you don't have a way of differentiating your drug based on the outcomes it achieves, what are you actually measuring it on? You can measure it on some clinical factors, and if you look at a lot of clinical trials, you'll have very detailed like vital signs or biomarkers and changes in those. But if that's it, there's not really an objective sense of what is that from a value perspective. And so you don't have much to argue on. So all you can argue on is that, let's say, improves survival, one starting point, and after that it's kind of an open race. And it's posturing, and then really the only thing you can focus on is price in order to optimize your value. And everyone will argue your price is too high, and you'll argue your price is too low, but you won't have really a good sense or basis to make a decision on. Finally, governments. You have a fixed pot of money, and unless one raises taxes, that pot of money reserves or stays relatively fixed. How do you allocate your resources? How do you decide if something is worth it? And how do you actually make a credible decision? Right now, in many cases, it's only based on cost. Costs more, we don't have the money, let's argue this one. That can't be the way you go about it because it fundamentally disagrees with the primary responsibility most governments take on, which is we want to improve the health of our population, not decrease the cost it takes to manage the healthcare, but improve the health. So you must consider the health when you're thinking of cutting costs. This is where having a measure like value comes into play. By having that, it aligns your incentives where everyone can agree that our goal is to have the best possible outcomes at a cost we can meet. And if that's what you can do, it gives you the foundation to have any kind of discussion you want to on is something worth it, which is the primary issue we have today, where you actually can't classify as something worth it in a legible or credible fashion. So, sounds like a good concept. Does it work? Where has it worked? Who's using it, and kind of, is there any proof that this actually is a viable way of operating a health economy? The answer is that this is no longer theory. LOUISE was mentioning that when I first started ICHOM, it was still kind of on the outskirts. And I'd really say that value-based healthcare has come into its own probably in the last 2 years, where countries have been slowly adopting it and slowly pushing it forward. And many countries, I'd say actually mostly in Europe, have gone the step further where they are doing outcomes measurement for multiple diseases and are tracking costs against those outcomes and starting to base their policy decisions upon it. A few examples, and I know because based slightly on some of the patient groups that I heard are in the room, but if we think about where has this outcomes measurement been shown to work very successfully in better management and also allowed one to influence the discussion on what is smart to reimburse and what is not smart to reimburse. Maybe start with Sweden. And Sweden's a really interesting country where they have a culture of measuring this, and they have 110 different disease registries that actually do this and measure it and transparently report it between kind of hospitals. But one which I'll focus on is they have something called the Rheumatoid Arthritis Registry. And what they had seen was that there was massive differences in the overall health of people who were living with rheumatoid arthritis between the hospitals they saw in Sweden. And they said, well, this can't be. Why do those differences persist? And so they started measuring a standard set of outcomes, which were really around pain, number of flare-ups you have, and things that would be very disease-specific to rheumatoid arthritis, and said, what is driving these differences? And what they found was, for a lot of it, it was that they couldn't actually know when these flare-ups or when issues were likely to happen in the at-home setting. So patients, because going to the hospital is quite a difficult thing to do, it involves appointment, it involves sometimes a long drive. In Sweden, it's a very large country with a small number of people, and so geographically they're quite dispersed. People weren't coming in until it was an absolute emergency, and that meant that they were kind of going up and down in terms of health. And so they instituted a system at one of their hospitals where they called it the open tight system. They would monitor people at home weekly, measuring their outcomes, and they would be asked to respond on a pain scale and overall disease management scale. And they took that, and they actually decided whether or not to bring the patient in based on their reported outcomes. If you looked like you were getting worse, we call you in quickly. If not, you stay at home. They were able to not only improve subjective kind of measures of quality of life, pain, et cetera, but actually objective clinical function, things that are very hardcore kind of biochemist measures like C-reactive protein or overall inflammation, and things that people try very hard to do with drugs and really weren't able to do, just by measuring those outcomes and using them to monitor patients and understand what was happening there. That's one discrete example of how this kind of thing can be used in patient management, but a very successful one in Sweden. Another one, let's say from a cancer perspective, at Memorial Sloan Kettering down in New York, again, they were trying to figure out how we can start to first look at the different cancers we've got and standardize the outcomes between them between hospitals so we know who's achieving most and who's achieving least. And they went to their group, which is called the Alliance of Dedicated Cancer Care Centers, represents, I think, the 12 largest cancer care centers in the US, MSKCC, MD Anderson, all names you know, and said, how do we all start measuring something? And they started measuring actually the prostate cancer standard set that ICHOM had created, which I was there for. And they started, again, looking objectively, what are the differences in outcomes between our hospitals and how we can achieve it? And immediately they saw it, and they said, okay, well, why are these differences happening? In prostate cancer, it turns out it's actually the type of surgery you do. There's things called nerve-sparing surgeries and non-nerve-sparing surgeries, but the summary of it is that what they were able to do is learn from one another and improve those outcomes. And they were able to then actually argue and discuss between themselves and come to a sense of what are the standard ways we treat these patients, and each time there's a new innovation and someone's achieving better outcomes, how do we bubble that up? And they're doing that very successfully there. The idea here is that this works both at kind of a national and a hospital level. As a concept, it's been proven to work and that it can improve your healthcare. And so maybe last thing, because I think from a time perspective I'm probably getting close, is what can patient groups do to be part of this? First, I think that I don't want to limit you with my suggestions. There's hundreds of thousands of things I think that different patient groups can do to be part of this change or this movement towards value-based healthcare. But the places people have been especially successful in other countries has been, first, be part of the group that actually defines the outcomes that you think matters for your patient population. If you're the Rheumatoid Arthritis Registry, if you're the, Hem-Oncology Registry, if you are the Hip and Knee Arthritis Registry, whatever it is, take part and pair with your actual, physician group to come up with a standard set of outcomes that you think is worth measuring. Now, that sounds like a big task, but these outcomes have already been published. Actually, ICHOM, the organization I used to work for, has published outcomes across 32, I think, disease conditions now. And so you can actually take these, slightly modify them for your population or keep them as is. I would suggest the second, but it's your call. But that's your first way, which is actually come up with what we want to measure as the outcomes that matter most to us to define whether healthcare is achieving what we want to achieve. These are already published, they're already there, there's something for you to work with. The second is actually push for those to be measured. I think that it is easy for policy people or sometimes even clinicians to kind of push this up and for governments to say, well, that's just another measure that we have to add on or there's going to be more costs associated with it. If patients say this is the most important thing for us, which is to know what is being achieved for us from a healthcare perspective, and we think you should measure something that is standardized between groups, it would be a massive, massive benefit to everyone. And so that would be the second thing, push for that measurement. And the third is, and I would say, is think creatively on how you can use this in your own condition today. You don't have to wait for the whole government to come together and start measuring this. If one patient group decides to do this, and they're doing it across all their members, and their members are tracking this on their own, physicians will take interest in the data. Naturally, they will. And that'll be a way of having a groundswell start to this. And so don't wait for everyone else to act. I think there's a way of getting this started at a very small level, whether it's the hospital level, whether it's a clinic level, whether it's just your patient group's level. But any one of those works to get this started and starts the improvement cycle. And with that, I'll pass on.
Thank you.
Thanks, Andre. So Andre kind of gave you that context of what is value-based health outcomes and what's happening globally and how do you start to think about it. What I'm going to try and do is paint a little bit of a picture and why I think Louise has asked me here about why I'm optimistic that Canada is a good start, has a good start and a good foundation upon which to build it. So Andre talked about outcomes and then cost effectiveness around that. In Canada, I'm going to give you the landscape of how folks are starting to view value-based outcomes and how there's pockets of innovation around this in terms of adoption. And I want you to think about it on three fronts. First, what's the context? What's the political? What's the economic? What's the appetite around it? And where are we seeing that across the Canadian healthcare system? Second is the system itself. For value-based outcomes to be successful, there are certain components that you need to think about. How integrated is the system? What is the role of the patient? Are they active? Are they participatory? Do they have a seat at the table? What about other providers and care providers and community providers, and how are they integrated in the delivery of care? And then last are supports. In order to define an outcome and measure an outcome, you need to have data. You need to have information. You need to have ability to collect, standardize, and know that. So there are certain system supports that are needed to do that. You also, Andre talked about incentives. You need to align the incentives. It's not just about payment, it's also about behavior and risk tolerance, and perhaps getting out of that comfort zone and doing things a bit differently that sometimes we have a hard job of here in Canada. So in those three elements of what's the context, what's the appetite around that, the second is, what's the system, how integrated is it, because it can't be pockets, it has to be a system approach. And the last around those some incentives, how is Canada in this regard in terms of being, perhaps a bright light on adoption of value-based outcomes? We talked about the World Economic Forum report on value-based. There's also another report by the Economic Intelligence Unit out of The Economist that ranks countries around the world on how well they are positioned to adopt value-based outcomes. And this is also why I'm optimistic. Benchmarked against dozens of countries, Canada fares pretty well on the top as moderate in terms of being able to do that. It has high potential in terms of willingness, it has high on the system integration side, and it's moderate on some of those aligned incentives and some of those other context elements. So now, what does that actually mean in the Canadian context? I kind of want to do a little bit of a west to east on that one and give you a bit of a sense of where I think the opportunities are and give you some examples of how value-based outcomes are starting to get a foothold in the Canadian system and what that means in terms of how we can take it forward. So we'll start in the West, which is perhaps our most integrated type of health system. If you look at BC, Alberta, the Prairies, Saskatchewan, Manitoba, there's more integration of health systems out there than perhaps in the rest of Canada, even though we're seeing integration across the country. But the one that I want to call out is Alberta. If folks are familiar with the Alberta landscape, you have things called strategic clinical networks. Anyone in the room familiar with SCNs? I know there's some folks from Alberta here and what have you. So what's interesting about strategic clinical networks is that they are disease-based. They're targeted at some of the highest pressures in the health system. So there's ones where you might be able to address some of the costs, some of the access, and some of the not great outcomes that you're seeing in that. And what's interesting about them is that they're bringing together providers, they're bringing together researchers, they're bringing together increasingly patients at the core of it, which is an interesting change because they weren't at the table in strong points originally, but they're also bringing innovators. So whether that be medtech, biotech, and to some extent now increasingly pharma, around the table in deliberative dialogues on what is the issue, what are the outcomes we're trying to achieve, trying to define those outcomes collectively. So Andre talked about, remember, getting that kind of shared understanding of what an outcome is, and looking to see what can we do differently. Sometimes it's process, sometimes it's people, sometimes it is about a different clinical intervention to change the outcome around that. That has been only 5 years in existence. There are 15 strategic clinical networks to date on that front, ranging from bone and arthritis through to cardiovascular, to our oncology, so a range of different disease states. And it is the beginning of that type of outcomes-driven decision-making that you need in order to really build a value-based healthcare system. It's still in its infancy, though. It still needs more awareness, and it still needs more outcomes measures around that to do that. One thing that I see needs to progress more on the strategic clinical network side is who's at the table. So as I noted, increasingly patients are at the table, but they haven't always been there. And that's important because very much key to value-based outcomes is the patient-reported outcomes side of it, not just the clinical indicators around that. Andre talked about, pain management, ability to have the kind of life that you want to lead afterwards. So PROs, patient-reported outcomes, are an important part of that. That's just beginning to be integrated into the strategic clinical networks, and that's an important part of it. But Alberta and those kind of networks and the roles that industry, the role that decision maker, and the role that patients are playing in it are an important start to anchoring what you need for value-based outcomes. Moving here into where we are today, Ontario. Political sort of alignment, integrated system, aligned incentives on this front. While Ontario is blowing up its system right now and reorganizing on many different fronts, we're integrating local health integration networks with community care access networks. We're doing lots of different reforms, good and bad, on innovation and drugs and technology on that front. There are some interesting things happening here that help to lay the groundwork for value-based health outcomes. First and foremost, we're finally trying to get a handle on cost. What is the cost of something? One of the most fundamental things in value-based outcomes is, do you actually know the cost of what it is that you're trying to deliver so that you can try and understand how is it supporting the outcomes that I want to get? In Ontario, it's very difficult to understand what the cost of a care pathway is. If you're diagnosed or before diagnosis, you have symptoms, you go through, you get diagnosed, you have your care plan, you might have different kinds of clinical interventions. It could be surgery, it could be drug therapy, it could be other types of therapy. You have some kind of response to that and then ongoing. What does that cost? The different actors along the stage that intervene on that front, it's very difficult to get a handle on that. Ontario now, though, has been looking at, for a number of years, first health system funding reform, where they're trying to tie the funding to outcomes that they want through things called quality-based procedures. So we'll look at a procedure, we'll try and identify the cost, and we'll pay you based on the quality that we're thinking of getting that. But more recently, it's the idea of integrated funding models. So if someone is going through a care pathway, whether it's through a hospital or a community, what is the total cost associated with that? And then what is the outcome that we want to achieve, and are they aligned? And then how are we paying people for performance based on that? That's a couple of years underway now, and we're starting to see some of the results on how that's doing. Is it changing behavior? How are patient-reported outcomes changing in the areas that we're looking at? But that idea of integrated funding models, so it's not just about those individual siloed payments, which is often in Canadian healthcare, people are fighting over who gets what money for what services. They're trying to put it along the patient journey as opposed to the clinical intervention. That's a huge shift. It's just starting. There's research and data to get the evidence around that here in Ontario right now, but that will very much be an important foundational piece to delivering value-based outcomes. If we move to the east, small but mighty is what I call the eastern provinces, and that's why I think even though you've got great fundamentals in Ontario, great fundamentals in Alberta around value-based outcomes. The interesting thing about the eastern provinces, if you look at PEI or Nova Scotia, and full disclosure, I'm from Nova Scotia, so it's close to my heart what's happening there, as my parents age out there now. They're small but mighty. So the ability to transform and get their arms around a disease state or a particular outcome that they want to measure and control is easier just from pure size and their ability to control the system. PEI, for example, has said, we want to do value-based healthcare. we've got an island, we've got a defined population, small geography, a good subset of folks that we can get our hands around who will partner with us to do this. So many companies that have been involved, and Medtronic's been one of the leaders in value-based healthcare. They've done quite a bit of it in Europe. They're looking to Canada increasingly on where they can do this, in particular cardiac interventions. They did a cross-country tour and they ended up spending a ton of time in PEI of all places, in large part because of a political willingness and wanting to do something different, smaller populations that you can get your arms around. Andre said, don't boil the ocean, pick a disease state, pick something targeted. Don't try and cover all cancers. Pick one on that front. But with the eastern provinces, they're saying, how do we use our size to an advantage to try and tackle a particular implementation of a value-based healthcare measure? How do we use the ability to integrate better? How do we use our smaller geographies to that advantage? And PEI has it's been quite interested in it. Nova Scotia increasingly, as they've blown up their system and done the division between the ministry and then regional health authorities, and even Newfoundland now, as it looks to integrate its electronic health records, its health information systems, to give it a province-wide, a better sense of its data to look at not just patient populations, needs and demands, but also costs. Those are important fundamentals that you need to be able to do this. And that's why Canada is being seen as one of the potential leaders in driving the value-based outcome discussion because of the good foundations that it's starting to put in place. I know a lot of times we talk negatively about, the divisions across provinces, that we don't really have an integrated system, that we have fractured approaches to this. And yes, on the whole, it very much feels like that. But there are pockets of elements in there that are looking to lay the groundwork to be able to deliver outcomes, and that is a fundamental shift in how we think about delivering healthcare that we haven't seen in decades. And I think it's important to build on that rather than try and ignore it, because I think it's going to be important. So what does this mean for us here in the room today? Andre talked about the don't try and boil the ocean, pick some areas, and I think that that's an important one. What I would say is many of us in the room today work closely with different organizations, different ministries, different providers, and what have you. What value-based healthcare takes the most is folks willing to take a risk, willing to try and do something differently, perhaps not do it at a provincial scale, perhaps do it in a focused area. Find your cowboys or cowgirls out there that have some decision-making, some control, that are willing to work in partnership with you. It is a different partnership model than we're used for. It is about sharing risk, which is something in healthcare that we're not always able to adapt to easily. Because it's not always the payer that is making the decisions. It might be the provider, it might be the patients, it might be someone else who's providing the clinical intervention. That discussion is sometimes tough for us to have in the room because we don't want to always give up control. Sometimes it's changing who has the control and moving it around and getting a bit uncomfortable. So that's why you need your cowboys or your cowgirls out there who might be willing to take that with you. A second, I feel like you've said this already, but get at the table about where these value-based outcome discussions are had. The integrated funding models, where they're happening across the province here in Ontario. What is the role of the patient advisors in those programs? How are patient groups with the disease areas that are being looked at ensuring that their patient-reported outcomes are part of the decision-making in looking at the definition of value and understanding that cost versus value equation? That's critical. Participation in strategic clinical networks. There's 15 plus and growing by the day. There's an open call, I think, right now for patients to get involved and participate in them. They need to be at the table on those fronts as well. It's an important part of the value discussion. It is not just the cost side, the clinical traditional indicators. It is the pros that are increasingly driving the definition around outcomes, and that's an important voice that you have that need to be part of those discussions. Thank you.
Thank you very much. Good morning. I don't know exactly how much ground there is left for me to cover. You've heard from two excellent speakers, and I want to begin by thanking Louise for the invitation to be here. I think, Louise, the comment you were referring to. So I've spent most of my life working in health policy in various provinces, beginning here in Ontario, and then I became frustrated enough that I actually decided to run for public office, not really expecting that I would become a Minister of Health. But I walked into the position, I guess, with a lot of questions, with a lot of concerns as a result of my work over the years. And the very first piece of advice I received on the day I was appointed, I think it was within about 2 hours, was from a former Minister of Health who said to me, Fred, you know, you're going to love this opportunity. It's a great thing, but you've got to remember one thing in particular. Everyone wants you to fix healthcare until you try to change something, which turned out to be exactly the case as Louise suggested. And I think in some ways that's you know, where we tend to be a bit cynical about major transformation in healthcare in Canada emanates from this sense that we keep reinventing the wheel. We keep starting from a blank sheet of paper every time we want to try to address a problem. And of course that's not very efficient, but it's also difficult when you consider that, you know, the life cycle of a government is generally about 4 years in Canada. If you're a health minister, you know, you're doing well to get 12 to 18 months in the role. I was fortunate, I had 3 years in total. So you've got a short political cycle. You've got a budget cycle that's only 3 years, and it's really only the next year in particular that governments are focused on. So it's very hard to think about these larger questions like we're talking about today with value-based healthcare if you only look at it from the perspective of government. Real change, meaningful change, needs other partners to drive that change despite changes in who's in government, despite what next year's budget may bring. And that's why I'm always so pleased to be able to engage with patients and patient groups and support their work, because you're in many ways the glue that can hold all of this together. You can be the connector that we need to be, and not just program changes and funding changes in healthcare in Canada, but in the bottom line cultural change that needs to take place. I think TERRI, I agree with TERRI completely when she talked about the challenge of, you know, governments not knowing what things cost. We have a lot of people that think they know what things cost in healthcare, but very, very few people who actually have taken the time and analysis and have the data to understand the value of what it is that we're trying to deliver. When I was young and I started out as a health planner, we used to go to a lot of lectures from prominent health economists of the day, people like Robert Evans. And we believed, and I still believe today, that healthcare in Canada is very much a public good. But that does not mean that healthcare is immune from advances in technology and science. It's not immune from market forces. So if you've done work with pharmaceutical companies, you'll know that we're about 2% of the global market for pharmaceutical companies. And then within Canada, there's a lot of competition and a lot of consternation around our little 2% and how that gets divided. If you're in government, politicians love to talk about healthcare being a value and a public good. We very frequently associate it with our notion of being Canadian. What does it mean to be Canadian? We have free healthcare. Well, as you know, more so than probably anyone, healthcare is not free. And so some of those sort of baked in notions about the nature of healthcare and what it is, and stopping the discussion because it's an important value in our society, are in the way. And so that's why I want to echo, and I won't go over the same points, but I would highly, highly endorse what Andre and TERRI have said to you as to some of the ways you can get involved in this discussion about how to have a value-based healthcare system as opposed to one that is just focused on the cost of the inputs into the system, be they drugs or physician services or other costs. So I want to just spend my few minutes here. I just want to talk to you a little bit about how I believe governments are thinking about healthcare today, financially and politically, and hoping that context might be some help to you. And then I want to talk a little bit about strategies as well that might be helpful to you going forward. So forgive me if I'm repeating statistics that you know, but so when I started my career here in Ontario, healthcare was about a third of the provincial budget. Today in many provinces in Canada, including Alberta, healthcare is approaching 50% of total provincial spending, which is, it's a lot of money. I mean, my experience with people is once you start talking above $1 billion in terms of government expenditure, people's eyes sort of start to glaze over, and it's hard for people to, to imagine the problem in allocating that amount of money. Not very difficult to do in healthcare. What we know, of course, is that although we're high spenders, we're in the top of the OECD countries in terms of our per capita spending. The performance of the Canadian healthcare system is pretty much middle of the pack, whether you look at the Commonwealth Fund rankings or the OECD rankings. We have been very consistent over the years in fairly mediocre performance, obviously pockets of excellence and some things we do well, but we don't do a lot of things well consistently, and when we do them well, we don't leverage how we've accomplished that for the benefit of the whole country. And a lot of people will throw their hands up and say, well, this is because, we're a federated model, the provinces control healthcare, it's really pointless to expect us to coordinate our efforts and make sure the very best things have the highest opportunity to flourish. And so for me, this is one of the reasons why value-based healthcare is so important. In the equation that Andre described, it's the denominator, and I think that's how you should think about it. It's the common base that no matter how, restricted our resources are, our spending power is in healthcare, value is that common denominator that we can all relate to. Whether you're a minister trying to put together with your department a budget for next year for your province, whether you're a hospital administrator, whether you're a patient organization, trying to decide how you're going to direct your and what I know are in many cases very, very scarce resources. Are we going to focus on lobbying activity? Are we going to become experts and gather data on things like preferred outcomes that should be possible for most of the patients and families that we're serving? So this is one of the reasons why I think value-based healthcare is so important. A couple of reasons to be hopeful. You might think my logic is a bit twisted here, but if you think about that 50% and you think about the day when one province gets up and says we're now spending 50% of our total budget on healthcare, that is a much bigger problem that I think most people want to avoid, particularly politicians, because once you hit that 50%, the next dollar that you spend on health is an opportunity cost. It's an opportunity cost for sending your kids to university, for building infrastructure in your community. Healthcare then becomes a public policy problem for other priorities that people have that can be argued to be equally important. Nobody wants to see that day come in Canada, especially anybody who's a minister of health. No one, I can promise you, even with 46 or 47%, whatever it was in my case, you're not standing up and taking a bow at your cabinet meeting or your treasury board meeting because all of this money is allocated and you think you're doing great things with it. So I would think about that. I would also go back to Terry's point about the strategic clinical network. So when I talk with patient organizations, a lot of people believe, and understandably, that the focus needs to be on lobbying the politicians. Louise is an expert at this, as you know, and maybe she'll have a degree program one day that's available. But getting their focus and attention, and that is absolutely important. But you also want to focus on people working within the system who can make a sustained effort to pursue the goal, in this case, of establishing value-based outcomes and then forcing the system to pay for the value as opposed to pay for the costs of the inputs that go into the system. Remember, and this is, I wanted to say this particularly about drug budgets, and there are people in the room today that have the very, very challenging job of trying to manage provincial drug plans and those budgets. what do you think about as a minister, as a senior leader in government? You've got a finite amount of money for one line in the ministry budget. Your only decision, and a lot of your budget is allocated years in advance, so your only decision is where are you going to spend the next $1 that you might receive from Treasury Board for your drug budget. The system is, the environment is not designed for you to think about the value that's being achieved for the dollars that you are spending. So it's, what I'm trying to say is it's an incremental mindset around how we spend drug budgets today. I can see a future when we set up the strategic clinical networks in Alberta. As Terry said, we got patients on them, then we got industry on them. I can certainly see a future where groups like those networks could quite wisely be delegated more authority by a Minister of Health to say, you've done the analysis on the value, you're closest to the patients and the families that are benefiting from the medication. We're going to devote or delegate more authority to you to make spending decisions in relation to pharmaceuticals or devices. So think about a future where decision making is at lower levels, and don't forget to invest your time and effort in those people, not just people that are sitting in elected office today. So those are a number of reasons I think it's important to be optimistic. The other part I would say, and I still think it outweighs or it doesn't stack up against all of the opportunity, but the future in a healthcare system in Canada where we're paying for value as opposed to just paying for inputs. As Terry suggested, and so did Andre, it's a very different kind of future. So today's black and white provincial drug plan, more or less where a drug is either on the list or off the list, most times it's equally available to everyone. That is not necessarily going to be the future in a system that's focused on value, where we have outcomes, standards that are determined using evidence, and where we're monitoring compliance with those standards. What that may mean is that there'll be a sharing of risk in terms of paying for the drug, but patients may not be necessarily guaranteed the right to try in the same way that we might think of that today. Because the drug is available, it may not necessarily be appropriate for all patients. Clinicians and patients are going to have to work a lot more together to determine how that risk is shared. With respect to the listing of a drug, there could be start rules, and there could be earlier access that comes from a value-based approach, because we're gathering the data and making decisions as the data comes in. But there will also be decisions around stopping the use of some therapies that are not as effective, not effective on their own, or not as effective compared with other drugs. So it will be a different world. It will not necessarily be gray, but the fact that we're collecting the data and basing more of the decisions on evidence means that there will be greater variation in what people access and under what conditions. So thinking about that sort of a future and how we keep the patient voice strong and support patients, not as people who are being centered upon or focused upon or any of the other words that are used today, but that are actually partners in the decisions around their care. And there doesn't get much more poignant than in a situation like this. So this is a great opportunity for Canada to get out of the rut of just looking at budget lines each year and making adjustments for cost of living and population growth. If that's all we do, every time we spend another dollar, we're simply buying the same unit of inefficiency that we had in that part of the healthcare system the previous year. This is a real opportunity to focus on value, to unleash, to stop doing things that don't make sense and are supported by evidence, and to start investing in your ideas and your contribution to this discussion, be it the data that you're providing, the capacity for patients to fully participate as partners at decision-making tables. All of that work and much more that you're doing, you now have a chance, I think, by joining with some of us who are interested in this, to turn it into a major contribution of value to a much better health system in the future. So I'll leave it there.
Thank you. So we're going to open that up to questions, but first, we're going to turn it over to what Sophie referred to as our patient Greek chorus. That's my terminology. I hope they won't take offense by that. Martine, maybe you want to join your two colleagues over here, and we'll ask each of you to introduce yourselves and to share some of your sense of what you heard and kind of how it feels to you from your patient group perspective.
Okay, thank you very much. I'm Martine ELIAS, and I'm with Myeloma Canada as the Director of Access, Advocacy, and Community Relations. And Louise knows that this whole value-based healthcare is really close to my heart. So, wow, what a panel. Thank you very much for bringing everybody. I certainly have a lot of, thoughts, but I'm going to limit it to three, my top three, so I can pass on the mic to my co-Greek forum, I guess. The first one is, this is all great. Looks like a perfect system if we can get there, but how long is it going to take? Patients are waiting. I know I work in the oncology field where the importance of life and death is very, very prominent in patients' mind. So, we can't wait very long to get the perfect system. That's my first comment. My second comment is, I've been following a lot of the work that Bernie Sanders is doing in the US and bringing the whole question about the healthcare system and comparing Canada to the US. He has a whole series, if you go on his Facebook, where he provides example of why the Canadian healthcare system is much better than the US. And I agree with him, I totally do. But we're at the time of change, and although we have a great healthcare system, I think it's important that we look at how we change it, because it's going to need to change. And based on the comments from the panel, it's certainly at the forefront. The last comment that I would like to make is, when you think about governments and paying for drugs or paying for healthcare or paying for hospitals, they look for predictability. And I'm not sure I understand, or I can see where looking at value-based outcomes can help that predictability. And I'd like to understand a bit more about that, because if you look at sort of how the PCODER or CADIS makes the recommendation, they look at QALYs, which is very simple. Put a line in the sand, decide if it's worth paying or not, and then the provinces can look at the information to decide they want to pay for it based on the negotiation with the Pan-Canadian Pricing or Pharmaceutical Alliance. So how do you make that decision? Because the value to me may not be a value to somebody else, and government looks at predictability models of the entire population. So that's something I wanted to comment on.
Hi, I'm Linda WELHELM, and I've been living with rheumatoid arthritis for over 30 years, and it doesn't get easier as you get older. So just a couple of things that struck me is that everybody agrees change is needed, but nobody wants to change. And I think those of us that have been around this table for 20 plus years or more can certainly sympathize with that sentiment. And the other comment is that we spend a lot of money on healthcare, but we really don't have great outcomes in this country compared to other countries. So I think those are really two stark revelations that aren't revelations to me, but I think would be to many. The other is the importance of measuring the outcomes that matter to patients, and how do we get there, because outcomes that matter to me as a patient aren't the same outcome that's going to matter to somebody else who's living with rheumatoid arthritis. They may want to run a 26-mile marathon. I'm happy to be able to walk, 2 blocks down the road. So I think that's going to be a challenge when we're talking about measuring those outcomes. I think the other thing that struck me is how do we implement outcomes and the outcomes that matter to patients? How do we move to that kind of model of healthcare? I know we talked a bit about patient engagement and patient involvement, and we hear about great things in Alberta where we have the strategic partners and networks and patients involved. And I can tell you, I am from New Brunswick, so when Atlantic Canada is mentioned, it's always PEI, Nova Scotia. New Brunswick never gets mentioned, but that's my pet peeve. But they don't engage with patients in Atlantic Canada. They really don't. We do not have a voice at any table, any kind of meaningful way, and that it's got to change. And no matter the wonderful things that we can do with our small populations there, they aren't going to matter to patients if they don't start involving patients in that discussion.
Thanks, panel. It was a very interesting discussion of a philosophical matter that. Do I have to turn this on?
I just want you to introduce yourself.
Pardon me?
Just make sure you introduce yourself.
My name's Phil Upshaw, and I'm the policy advisor to the Mood Disorder Society of Canada. We're a mental health organization based on the issues regarding depression, anxiety, bipolar disorder, and stuff like that. All issues which have been reasonably well ignored by our health professionals and our government folks for over 100 years. We're the most discriminated, stigmatized group of disability organizations. And so it takes a little bit of whining to get anybody to listen, and I don't like to whine, but I do a lot of it. So the first thing, if I may just point out, I'm sure, is everyone here participating in the PCHO review? Yes? PCHO review is a pan-Canadian health organization review that's being undertaken by 2 senior folks, one Danielle Martin, who I think you know from Women's College, and PJ Foray from University of Alberta. And their goal is to review the pan-Canadian health organizations, which include CADTH. From my perspective, they also include the Mental Health Commission and the Canadian Centre for Substance Abuse. But for this particular group, I would think it would be something that you'd want to look up. I have a press release here somewhere about it. But my view is, and I right at the outset, these are my views. They may or may not reflect the views of the Mood Disorder Society of Canada and our CEO, but hopefully they do in general terms. But my view is that CADTH should be gone, and I think this is an opportunity to put in a brief to the reviewers. They have a substantial staff. They are receiving significant numbers of briefs, and the opportunity to move towards value-based outcomes might be there if we can accomplish some changes to the CADTH organization, make it a little more relevant if there is that opportunity. So I would encourage you to take a look at it because I think it's one of the initial steps towards what we want to achieve. I guess my other comments are that I really do I thank you. I think you spoke really well. The issue for organizations like ours is to get at the table, and I think that sounds like a lot of people have that same issue. And without patient engagement, full patient engagement, I'm not a fan of having patients sit at the sidelines or tokenism. Or I think patients should be fully involved in being able to access the data that allows them to make informed engagement with the healthcare providers and government. Data in the healthcare side of things is woefully lacking, or it's tragically hidden from the public. Either way, it makes our efforts at advocacy very difficult. So those are, I'm not sure that I've dealt with the what does it really mean to patients, but I think there are some elements that what you're talking about means to Canadians that I think in Canadian healthcare, which is really important, from the patient organization perspective, we ain't got the time or the money to really focus in on what you're suggesting. So maybe what everyone has to do is decide on a baby step that helps them move towards that. And New Brunswick, as we all know, has our new federal minister of health is eagerly talking about New Brunswick. Good old Moncton. Thank you.
So would any or all of you like to respond in any way to what you've heard? Andre, I see you shaking your head.
Definitely. Maybe I'll start off, but I'll try not to respond to everything. Otherwise, I think there's a 2-minute answer. But so Martine, I think I picked up 3 questions. I think you said, how long will it take to get there? A little bit about the comparison between us and the US, and it seems we're better than the US, but what does that mean? And then how do you think of predictability in payments? Maybe I'll start at the bottom, predictability in payments. Value-based healthcare as a concept, and TERRI started touching on this, relies on us being able to pay for an outcome rather than for a visit or for a test or for individual service. And so the idea with an outcome is that an outcome is usually at the end of a fixed period of treatment. If you are someone who's having, who is diagnosed with prostate cancer, you would say that in that scenario, diagnosis would be the start of your period, and the end of your period would probably be some time of monitoring, 1 to 2 years probably after that, after which you've met a certain set of functional and mental kind of outcomes. And those would be what you would call as your set period. Now, you would actually get paid for care within that period. And these are usually called bundled payments, and they have been shown to be rather successful in multiple countries and multiple contexts. And the way they bring consistency is that from a provincial side, you know roughly how many cases of prostate cancer you're going to have in Ontario per year. This is not rocket science at all. And if you know how many cases you're going to have, you can very quickly say, well, this is how much our bundled payment's worth, this is our expenditure there per year. Now, from the hospital and physician side of things, the question becomes is, how do you manage a patient that is on one side, you have patients of all different shapes, sizes, and colors, and some will cost a lot and some will cost a little. That's true at an individual level. As soon as you get to critical mass, and this is different for each condition, but you do have pretty reasonable bounds within that usually falls. And what they've done with bundled payments is they said, as long as your patients meet these standard criteria, they will pay this much. If you decide to spend more healthcare resources on it, that's your job. If you do less, that's your job. But you have to meet these outcomes. If you do it without the outcomes part, you'll just spend less, which no one wants at all. And so that's how it brings some consistency to both sides of the coin, the governments and the hospitals, and can work very well. The key is that you actually have to have an outcomes measurement framework that is in place, and you actually have to agree on the outcomes that you're going to pay for this bundle based on. And that's the hard part. It's starting in the US, the Center for Medicare and Medicaid Services started a bundled payment for hip and knee osteoarthritis for this. They kicked off one for heart failure. They've said they want to do 80% of their payments by 2020. Let's see if that happens given current governments. But it is likely on that pathway. If you go to Europe, Sweden, etc., Sweden and I think Netherlands would be the 2 places to look most closely, where they've done this extremely successfully and shown actually pretty interesting cost reductions through just less utilization of services. So that's that predictability piece. In terms of how long will it take to get there, I think that on that side, it's easy to say this could take forever if you want to look at all of it, but any one hospital can start this. And in the US, that's very much how it's happened. There's certain institutions that have kicked this off, Kaiser, to some extent, Memorial Sloan Kettering, the cancer centers, Partners Healthcare in Boston, and their associated hospitals, and it's growing that way. And when you think of one center or set group of hospitals doing it, this is millions of people. And so if we get to critical mass, about 50 million people, and that's being serviced in this way, and they're all measuring standardized outcomes, that's actually the way to grow up. So what I would reverse that question is say, how quickly can you start it in the area that matters to you and the disease condition that matters to you? And I think the answer to that is pretty quickly. Going down the list, I think that, Linda, you asked a few things around what are the outcomes that matter? And the outcomes that matter to me are different from the outcomes that matter to somebody else. I think that's very valid. There are general things that matter to, or there are things that matter to all of us. Our goals might be different. So if I am someone with rheumatoid arthritis and I am living and I want to say, I want to run a marathon versus somebody else who wants to basically have a comfortable life with less physical activity. My physical activity goals are different, but the outcomes I'm actually measuring, which is ability or functional status, would be similar. Pain, functional status, these two are constant. Now your personal health goals might be different. And that's a different scenario. And actually knowing how to get to those personal health goals requires that you measure outcomes so we know what treatments actually end or can get you to those different health goals. But the outcomes are similar. So I wouldn't say that having different health goals predisposes us to needing different outcomes for everyone. You can have similar outcomes, it's just that you'll have different goals along those trajectories. And that's some of the most successful ways this has been used, and actually particularly in mental health in the US, which is that you actually can now start to have a care plan that takes into account what patients want along a structured framework. Because it's hard to ask someone, what do you want? They'll tell you all kinds of things. If you say, what is your pain goals? What is your goals in terms of work? Do you want to be able to get to work once a week, twice a week, et cetera? From a physical functioning thing, do you want to have a marathon or do you want to take a walk? These give you something to center on. And so that's where I would take maybe that discussion, which is that it's not so much the outcomes are different that you want to measure, but that what our goals are. And the only way you can get to different goals and care plans that meet those goals is by having a standard set of outcomes so we can all respond on it. Then I think the last thing I'll say is that how do we implement all of this? And I think how do we get patients to the table? I think implementing it, it starts with measurement, and I think that's where patients can get to the table. Is that if patients are asking from our condition, we demand that you measure these things for us and track it, and we're gonna track it ourselves, so you're gonna get this data regardless. Suddenly you're in a situation where you're at the table because the information you have is what they need. If patients were to start a disease registry versus a medical society, it's a very reasonable thing to do, and it's happened before. And if you're tracking a standardized set of information, that becomes very unique and useful to every medical society in the world. And so I would say that currently your data about you is the one thing that can change the dynamic of how physicians treat us and how people are reimbursed. And it's actually your data. And since it's your data, you actually have a very strong place at that table to get it started. And patient groups can even take that small incremental steps of starting to think how we can look at our data together and start pushing this forward. So I would say demand that seat at the table because your data is actually the center of what everyone needs to make any of this happen.
Yeah, I just want to build on two of the points because Andre, you did do a very good job of hitting all those questions along there. So we'll start with the last about, how do we get at the table and how do we make part of it? One of the biggest tipping points around moving to value-based healthcare is demand, right? It is demand-driven. And right now, the folks who are demanding which ones do we look at, which kind of outcomes, are clinical providers or governments. Because they're the ones sort of talking about it. The third leg of that stool, though, is the patient. What outcome, what disease area do you want? That is most important to you. And that's the voice that's perhaps too low on the radar screen right now. And it is what Andre said. It's about defining what the patient wants as the outcome, as part of that conversation, as that third leg of the stool. Providers, clinicians, they're already out there from that pure clinical, more academic perspective, I can say that, no offense to clinicians in the room. And then governments are based on where they see the cost drivers. So there's only two inputs that are driving that demand for it right now. But for value-based outcomes to become part of the system, that third element of what are patients defining. So whether it's your patient groups, whether it's you as individuals, that's what needs to happen more, I would say, collaboratively and collectively right now. And pick a couple of points where they are. There are 15 strategic clinical networks in Alberta. There's a dozen or more integrated funding models here in Ontario. Those are publicly known. You can look to see where they align with different interventions, different disease groups on that one. And I think that that's very important. On the predictability side, Andre talked a lot about being able to know and align with the costs. It is a very different model than governments are used to today, because it is about risk sharing. Now, you can manage the predictability around it by setting that at the front end. So one of the key things around defining value-based healthcare is actually what are you willing to pay for the outcome? And you need to know the cost to be able to do that. And then what is the trigger for payment at the end? And that needs to be decided at the front end. Pharma actually has been one of the better groups globally at looking to create some sort of risk share models where a drug has a particular impact within a patient cohort or group at this sort of timeline. So this drug has a 70% effectiveness over 18 months with this cohort. that's a model then to begin to understand what that, okay, governments go, okay, I'm going to pay you at the end of 18 months once you've achieved 70% effectiveness across this cohort. That is when the big payment comes. Along the way, I'll give you a per unit for the number of patients that are being overseen so that there's some predictability and incentive for the drug as well as then for the government to be sharing it. But we don't operate like that today. We don't share risk like that today. So it's a very different conversation that governments need to get comfortable with. There's models, there's more than I think 200 or something risk share models around drugs around the world that are happening in that front. We're starting to see risk share on technology. MedTech actually might be leapfrogging pharma. MedTech's much more at the table on this than pharma is, quite honestly, and MedTech is leading it because in some instances what you're seeing, and you see this more in Europe, MedTech is actually saying, we'll take the responsibility for the whole care pathway. So we'll help oversee and work with you on it, and we'll manage the risk on it, and government, you pay us when you get the outcome at the level that you want on the other end. That's very uncomfortable for a lot of people to do it, but it's the type of conversation that actually changes the delivery of care and improves the outcomes out there. Ontario's probably the most active in trying to understand and do that. And they're working more closely with MedTech, I'd say, than they are with drugs on that front and trying to just define care pathways. They're looking at value-based innovation programs right now to roll out for different disease states, and they'll be looking to call and say, hey, who wants to come to the table and do that? So look for that in the very near future, see where the disease areas are, and then make sure that you look to partner or look to see who is going to do those value-based innovation programs, because that is going to happen within the next couple of months.
So just really briefly, because I think my colleagues have done a great job of responding to the individual points. One thing I don't think is well understood, just because of the way sometimes the listing agreements with pharmaceutical companies are designed. So we do have experience with risk-sharing agreements for particular drugs in Canada. The details are generally confidential, for the reasons that we talked about earlier. But as TERRI was just saying, I mean, it's not a new notion. And to go back to your point about, the predictability of costs, the thing that governments are, I think are now finally realizing, is that what is predictable is that the costs are going to keep increasing if we only do things the way we've always done them before. I guess what else is predictable is that not just demand because of aging population and changing demographics, but there's a whole new layer of demand that's created because of what is now possible. So if we think of immunotherapy, for example, in cancer as just one area. If you look at orphan drugs, I believe if you look at orphan drugs or drugs for orphan diseases and drugs in the oncology area, that's about 80% of the newest and the highest priced drugs that governments are being asked to fund today, not right now. They're not things that are already on the formulary, but things that are coming at us in the next few years. So they know that they have to figure out a way. It's not really a question of how do we make the pie bigger to pay for all these things. It's how do we make the decisions differently so that we're actually paying for what works. We gave some advice, I think all of us, around getting involved in defining the outcomes that are meaningful to patients. And that's really important. And just to go back to Andre's point, a lot of this stuff has been thought through ISHOM, which is discussed in your paper. So you can actually look at what already exists. The other thing that we could do in Canada, and it's something that really only patients can make happen, is we can develop more disease registries, and we can make them permanent, ongoing, and more sophisticated. There is some work that's gone on in Italy that I'm aware of, and actually there's some research at the University of British Columbia now, I understand, on the idea of certified disease registries. So what these actually, because you need the outcome defined, but you also need the data to support the decision making. So registries that are set up consistently, that meet a specific standard, that are funded to be ongoing, and where the data is freely shared, is also something that's really critical, I would say, to being able to implement a value-based approach. And, let's face it, folks, nobody has the data unless the patients are on board. So that may be an area that you could look at as well.
So I'd like to open it up to the floor if there are any questions. Yes? Sophie's going to bring you a
I'll be
mic.
running the mic around, so thanks for introducing yourselves as well when you present.
Okay. Yeah, thank you. I'm Dave McMullen with Myeloma Canada, and thank you panelists and patient panelists for your insights. The drug pricing process that we have in Canada, I believe, relies largely upon clinical measures. I think because they're fairly easy to acquire in a consistent manner across various drugs. I'm looking for any suggestions on how you might apply patient-reported outcome measures or patient preference measures in the drug pricing process.
Who wants to try that one?
We're pros after.
I'll take a quick shot at it. I think what it would mean is you wouldn't just add the patient outcome as a variable. I think you'd actually have to rethink the whole analysis that goes into pricing a drug, because so if we take the PMPRB side of it, for example, the agency that determines what the maximum price is that should be charged, that's really not a reflection of value. That's just a reflection of what a group of other countries are paying on average for a drug. Or if we take the current CDR process, which is based on a threshold, that cost threshold per quality, that might account for the clinical efficacy of the drug, but that's only one part of the value of the total therapy to an individual patient. It might be if you have arthritis, it might be your access to rehab, therapy services in your local community. It could mean if it's a mental health, it might mean, does your health care system actually pay for you to see a psychologist, not for cognitive therapy, not just to see a psychiatrist once or twice a year. So I don't think there's a simple answer to your question. We would have to rethink the analysis, and the output of the CDR process would be what is the value of the drug to the outcome that we know can be achieved for a patient. And then the pricing decision, I think you're still faced with payers and pharmaceutical companies coming together, but instead of the traditional type of bartering negotiation back and forth where a lot of the data is invisible, you've got what TERRI described, which is a negotiation that's actually based on things like risk sharing, because we don't know how drugs are going to work for every patient. One thing that really interests me, so if you look at an area like, Phil knows more about this than I do, but if you look at an area like major depressive disorder and the increasing number of patients who don't respond to the old guard antidepressant classes, there's a whole new group of drugs that can help people, but they don't have what they call a heterogeneous effect. So they don't have, or they're heterogeneous in nature, which means they don't have the same effect on every patient. They have to have a process of trial and error. Well, if your CDR system is designed only to compare a drug to, a similar drug that's already funded and its therapeutic effect, you don't have much of a chance for a drug like this that varies greatly in its impact on different patients. So we have to think this sort of part of the process as well, but I wouldn't start there. It's important to have input as patients, but I would really echo the advice of my two colleagues, about let's talk about what is value in an outcome here. What does it mean to actual people, and not just their health, their well-being, but also their family and their community.
And Fred's hit on this. Part of it is a shift in thinking. It's not about paying for a drug, it's about paying for an outcome, and that means that there is a care pathway that is for the individual, right? And I think that's the shift that needs to happen in the thinking. Yes, we'll still need to price drugs and what have you, but more fundamental is it's not about different singular interventions. It is about defined care pathways that lead to an outcome that is desirable and wanted for the patient, in alignment with the clinical provider. And that, we're not there. We're not there by a long shot on that front. Defining the outcomes is the first step, and then that gives choice to the provider, it gives choice to the individual about what their care plan looks like. It might be a drug intervention, it might be different types of drug interventions, it might be therapy, it might be other types of supports that are needed to get that outcome. And I think that's a part of the shift in thinking how we need to start talking about it, because then it's not just about the price for a drug, it's actually about what do we need to pay for to get the outcome? And that's a big shift in thinking that we need to start having. And then that will start to influence, as Fred talks about, how we start to price the inputs that support the care pathway for the individual for that outcome that you want.
Just as a really simple example, because I always worry that we're up here talking in, lingo, right? So if look at all of the discussion around the Hep C drugs that are now available, right, in the last few years. You don't notice a lot of debate about the prices that are being paid for those Hep C drugs. Why? Because the outcome is a cure for hepatitis C. So the contribution of the drug to that outcome is very, very high. With other drugs, it may not be as high. With drugs that don't provide a cure or that are only effective if they're used in conjunction with other kinds of support or intervention from the healthcare system. So it's around that pay-for-performance thinking. And if you look at where we interact as consumers, right, in the rest of the marketplace, a lot of industries have changed their business model to a pay-for-performance model. If you're saving for retirement and you consult a financial planner, you're very likely these days to encounter people who will charge you fees depending on the performance that they deliver to you on growing your hard-earned retirement savings. There's lots of examples in the consumer world where we actually don't question the notion of paying for the performance of something, but we have the data and we have consumer reviews and we have things to define what the value is. Why should that be any different in healthcare is the question that we're asking, I think.
Very much. We have 2 questions over here, so.
And I know we've got some over this way too.
And some of the back.
Yeah.
Thank you. Great panel, by the way. And it was a great conference. Ken Gagnon from the Arthritis Society. I got a question regarding the payment on the outcome. And for the old treatment, maybe not only for a drug, but for the old treatment, is that don't you fear that institution or health center will take care of the lighter case and let the heavier case non-addressed or on the side so that they are concentrating their efforts on those cases, but those that would have a dire needs won't be seen or won't be treated? Or don't you think that some center will become specialized in some region and then a patient that needs much more support will have to travel farther to get those kind of care? So how do you manage those care and how do you make sure that those patients that needs dire care or much more care will have those needed care?
I can start responding to that because actually I lived through part of this problem while working at ICHOM. The first question on a patient is not a patient, and so will we treat the less sick one because we're guaranteed our outcomes versus the more sick one? The answer to that is that from a risk stratification perspective, as soon as you get beyond the one person level and you start looking at groups, it's actually not impossible to say that these are the things which we would call as or descriptors that would make a condition more, what's it called, dire, and therefore someone should get paid more total as a bundle for that person, and also one's outcomes should be tempered within that patient group. So you actually can't say everyone with rheumatoid arthritis is the same. You'd actually substratify them. And that can happen, but you need large enough numbers. Numbers that do exist very well at the provincial or the country level doesn't really work at the individual level. And so that's how countries have pursued it. They already do this. If you think of payment, I don't know the Canadian payment system well, so I apologize for that, but let's say the US one. If you look at payment for something like a heart failure treatment, they'll have heart failure with or without major comorbidities, and they define the major comorbidities, and they go about and say, okay, your payment is X, Y, or Z, depending on which additive comorbidities you have. Think of this as the exact same way, and it's very possible to do. And the models, or the science behind it, is something that has been started to be worked on. I won't say it's all figured out, but is working in other countries currently. So I wouldn't think of that as our barrier. The second question you asked, which was, are there going to be centers of excellence that do this really, really well? And then, is that going to mean that I travel farther sometimes for certain types of treatments? I think that there are, depending on the disease condition or the procedure you're thinking about, there are things that where volume matters a lot in terms of how good you get. I would say radical prostatectomy is one of them. If you have a center and center does 2 versus 20 versus 100, you can actually probably look at the outcomes curve along that same trajectory. In those situations, you're naturally going to see that, yes, you will probably travel more for a condition like that, where it is very, very, very useful to have a center that does all this. Cataract surgery is an easy one, and it's an easy one for the outcomes debate, because there's a place called Aravind Eye Clinic in India, and Aravind Eye Clinic has the same outcomes post-cataract surgery as Mayo Clinic does, but they cost about, I think, $400 all in for a surgery, and Mayo is somewhere near $30,000, sorry. So yeah, there's a stop there in the room. And similar outcomes, and both are willing to admit it. There's very different input costs there, but Aravind actually is thinking of opening up clinics, I think, in the Caribbean and saying, come on, fly in, you can stay at the Four Seasons nearby for 2 weeks, and we can do the surgery, and you're probably okay. And still from a cost perspective, much lower. So in those situations where there is a defined period of care that can make a big difference in the overall bundle, it might make sense to actually have geographic centers. Something like rheumatoid arthritis, where it's long-term management, where it's a chronic condition where you're actually just seeing the patient in and out for the rest of their lives, that's a different condition. And for those, you still keep it quite separate, and it's having a system that supports that monitoring. So I think that we may have to be open to the idea of centers of excellence.
Thanks.
So I just want to be sure I understand. So I do, but I want to make sure we all understand. So really what happens is we do determine different populations. So I recall in reading the material, so there's the group that's called healthy adults, and then there's a group that's called frail elderly, and there's this. So we do actually subpopulate, and we recognize that both the cost and the outcomes in those different populations will be different and have to be treated differently. Is that?
Very much so.
Okay.
Otherwise, doctors would throw their hands up,
Well,
which they kind of do with mortality right now.
Which they'd like to right now, yeah. Okay.
Thank you very much for all the speakers, and thank you to the patients. Hand to the patients, please. I'm biased. I'm a patient. So going back to, I really appreciate that the care path. We know that right now in Canada, the main burden in the healthcare cost is twofold. Not only the chronic illness, most of the people don't have like Hep C, that you have a cure. A lot of us know that we'll live with the rest of our lives without a cure until somebody finds all the many cures that everybody's researching. But we keep thinking of the cure mentality, and that is not necessarily an outcome for the majority of people in this room. And so if the patient in their care path is to, for example, most of the patients want and wish alternative therapies, not just pills. So the patients need to advocate that. But when they go to the doctor and they're in a vulnerable position, they are at the receiving end of the care. I would suggest that there's a lot of pushback from the healthcare system, all the science. They will give you therapies that they know, but they won't give you alternative therapies because there's not enough research. But nobody wants to pay for the research. So it's sort of like the chicken and an egg kind of thing. So it's not research to support that better nutrition will make you better or more exercises will make you better, but nobody wants to pay for that. Nobody will benefit from eating better and exercising prescription, right? So then don't we actually, this is a little bit of garbage in, garbage out. I'm all for measuring. I totally believe in measuring. But if we will continue measuring what we're doing right now, the outcomes will be the same. It's just in a neat, chart in numbers. We need to actually go 2 steps back and go to the post-secondary educations and teach not only the healthcare professionals, but all of the other professionals, the technologists, the innovators, that this all needs to start to shift and change, and that yes, we need to listen to the patients more. And so what do you think would be the biggest barrier for wanting that kind of radical shift? Political, financial, etc.
Yeah, one of the benefits of going to an outcome is you actually force a different conversation between provider and patient. And the intent is then to have more choice in what can be part for that individual of contributing to the outcome that they want, and that from a clinical perspective you would want to get for them as well. So I'll give an example of my niece. She's 19 years old, and she was just diagnosed with high blood pressure and high cholesterol, and she's 19. I was sort of, what? You're a big soccer player, and these kind of things. And the first intervention that her clinician described was to put her on medication, to put her on drugs, and said, oh, you'll be on these until we can manage your cholesterol and what have you. And she said, well, what else can I do? I'm 19, I'm pretty active, I play soccer all the time. Is there no other way that I can manage this? Nope, we're going to put you on a prescription and this kind of thing. So she ended up doing the research and goes, what else can I do and what have you? She changed her diet. She changed just behavioral changes. She read up more about it to understand what was happening and this kind of thing. And she took control of that and managed it herself. And 6 months later, her cholesterol's down to a normal for a 19-year-old. She did it all through changes to eating, changes to other behavior, that kind of stuff. And that was so surprising to me from a clinical perspective that her doctor didn't have more of a conversation with her about other things that she could be doing. But that individual wasn't being incentivized to treat her for her outcome. That physician was being incentivized to see her treat the condition that she was in and what that person believed was the most effective way, get her out the door and get the next patient in, right? Wasn't incentivized on getting her the outcome that she needed and that she wanted to be able to do, where she didn't want to go on a medication because she's 19 years old and didn't think that that would be appropriate. Switching to an outcome-driven reimbursement, i.e. the incentives for the provider are to get the outcome for the patient and the clinical outcomes you want as well, forces a different conversation about what can best impact the patient outcomes that are desired, the health outcomes that are desired, and then what kind of evidence might be there. And yes, clinicians will still want to be driven by evidence to support their decision making, but also then what else will the patient be wanting to do? There's a lot of support now virtually that doesn't require people to travel. We have virtual care management. We have a lot of different ways that we can help manage, and we can be tracking our own information. How many of you have, Fitbits and those kind of things now to be able to see how your behavioral changes can impact that? That all needs to be part of that discussion with providers as a patient as to what can help you and support you. And that's, one, giving patients more decision-making and perhaps more comfort in doing it. But two, if you incentivize an outcome discussion, then the input discussion of what can help with treatment is different than it is today.
I just want to wrap up by saying, for those, if I'm right, and I'm sometimes am, but not always, I think some of the things you've talked about, and I'm reiterating this because I want you to think a little bit about some of these things when you hear all the next panels for the next 2 days. And so I gathered one of the very important things is partnerships in healthcare and across multi-stakeholder partnerships. I gather collecting, sharing of data, all kinds of data, very important. The dropping of silos, as I call them, between budgets and looking at outcomes rather than rewards in a particular budget is one of the keys here. And patient partnership, rather than centering around the patient. The patient's a partner in making the decisions. Are those kind of 4 of the key elements to this? Are there any other key elements that I've missed that you think people need to think about as they're listening to what's going on in the system right now, and whether in fact it's getting us closer to health outcomes or farther away from health outcomes, or it's agnostic to health outcomes. Because I really hope that you'll think about this as you're hearing what the system is doing now, and whether it's really getting us, closer or not. Is there anything else that we ought to be thinking about as we hear the rest of the panels? Are those the biggies?
I think those are definitely the big ones in my opinion. I would say that the thing you can think about for each one of those things is what drives us towards that. Because independently, having kind of more partnerships or less silos is very hard to do in kind of a silo. Just say, be less siloed, everyone's like, okay, we'll do it, and it doesn't really happen. If you all are focused on the same thing, which in this case is what we'd call a value measurement, so a set of outcomes we want to achieve for a patient population, and a cost number that we want to use to achieve it, it suddenly allows you to start to partner, to say, this is the care decision I want for me. It allows you to partner, say, we as a group of people are trying to deliver this outcome, so we can't have a silo because we actually all have the same metric, and we're being measured on that metric, and we're being paid together on that metric. And so think of that as being what forces you into this. And if you actually embrace the value-based system properly, you don't have a choice but to do all those things. And that's maybe what I would say.
Mm-hmm. Anything else? Okay. So I don't know about the rest of you, but this really resonated for me, and I gather you've already guessed that. And I wanted to let you know that if it resonates for you, and I hope it does, because we have to hold on to some light at the end of what seems a rather dark tunnel in some days, there are multi-stakeholders who are championing this. In Canada and internationally. And those of us who are interested are going to be getting together in the new year and starting to talk about how we can work together. This partnership building that you've all talked about as being crucial about this. So if this resonates for you, in whatever stakeholder group you're in, and you want to be part of the solution, I would urge you to let us know. You'll be able to talk about it, of course, in your small groups, because we're going to do that in a while. But I just wanted to let you know that this is not a theoretical, I'm not big on theoretical conversations, as most of you know. We're really going to try and start to move the agenda in Canada even farther than it already has been over the next year and beyond. So if you're interested in joining the party, please let us know. So thank you to our panel again.
Thank you very much.